The Inquisitees all have their nice gowns on, and so Chris, perhaps you could lead us off.
Yep. So it seems very inappropriate to have us dressed up in this on a hot afternoon, but that's really so that our Inquisitees can sweat. And we hope to make them sweat, but we also hope that you'll get involved in this and make them sweat too. So we're going to have some open questions, and you don't need to pull any punches here. You can ask them whatever you want. So we call this Inquisition on ossiculoplasty, and it's the good cop, bad cop routine. But the question, of course, really, who's the good cop here? Who's the bad cop? So I was thinking of David more like this, really. He's got to that stage of his life where he's saying, well, sometimes I can't really remember if I'm a good cop or a bad cop. Whereas for me, I'm more the sort of reflective type of cop. So I think I'm neither a good cop nor a bad cop. Jerome, like you yourself, I'm a complex amalgam of positive and negative personality traits that emerge or not, depending on the circumstances. That's me. Okay, so we're going to start with our first case, guys, and this is it. So you want to do this one, David?
Yeah, okay. So we have here a 30-year-old male with a right posterior superior retraction pocket, depth not known, with loss of the long process of incus. So basically what we're looking for is solutions to our problem here in terms of the reconstructive process. So we'll start back to front and ask you what we're going to do.
What are his symptoms or complaints?
So can you speak right into the...
What are his symptoms? Why did he come and see you?
Deafness.
So his hearing is down.
Yeah.
Has he had any prior surgery?
No.
Okay. And any drainage or
No.
other issues? Ringing, imbalance?
No.
Okay. Has he had a hearing aid trial?
No.
So being at a surgical conference, that's a very bad thing to say. But
Not necessarily.
yeah. But this is somebody that, assuming that you can do a good examination, this would be a good patient to put an endoscope in to see if indeed there's a deep retraction or if it's just a shallow
It's
retraction.
not.
It's not. So this is somebody that we would definitely consider for surgery, but I would recommend him do a trial with a hearing aid.
He's 30 years old. He's a bloke.
Hearing aids are sexy.
Not in the UK. Okay? So anywhere else in the world maybe, but hearing aids aren't sexy. He doesn't want one.
That's actually very interesting because in the United States, if we operated on this gentleman and he got a complication and we did not offer him a hearing aid trial, we would be medical legally liable for the procedure. So, we would, and my take on a hearing aid on a 30-year-old is very, very low. It's less than 10%. They all want to have it repaired and move
So
on.
you would offer, you wouldn't make him have a trial?
No, I would offer it and I would document it in his chart that we made that for him. So, and assuming he said no, then we would start having a discussion about what type of surgical options that would be in his best interest. And how far do you want me to go?
You're the cop.
You've got next slide? Yeah. Okay. So, well, we're talking about the options. These are the findings.
And by the way, with a shallow retraction pocket,
It was a shallow retraction
not do a
pocket.
CT scan.
It could be elevated out without a post-oral approach. It's a permeatal approach. It lifts out nicely. This is the finding at surgery. So the essence of what I want to pick up here is, what do you do with this kind of patient? Now, we have a hearing aid option. At 30, not going to get too many takers. So let's, you've given a nice outline there, so let's see what you would actually do here.
Well, first of all, I would check he's not a sniffer as well. That's a classic kind of sniffer's ear at the back like that. But anyway, so the options here are to do, to either reconstruct that with a hydroxyapatite cement, put it back together, or to augment that stay piece with either an incus interposition or an allograft. I personally would do something like a Dresden clip here because I just found it very reliable. It's been reliable in my hands. I would make sure that there's cartilage cover over the posterior part of the tympanic membrane doesn't retract. But there's many. I know Thomas has great success with the hydroxyapatite rebuilding these. I personally haven't, but I go to what I found reliable.
Okay, well, I just want to pick up on that thread of cement. Who here has used cement? And who here has a high success rate? Right? So I'm coming to you. Okay. No. This is led towards you. You've been set up here by Manohar. Let's talk about cement reconstruction.
Yes, I think this is an excellent case for cement reconstruction, because the advantage of cement is that you're not disarticulating the chain. You're keeping the chain intact. So there is nothing really to lose. There is somebody of a company, well-known company here in the audience, who is sleeping. Who were? No, he's sleeping so much. So, but I mean, but a TORP or an interposition ossiculoplasty would be an alternative, but there is always a chance that it drops off. What, in the worst case scenario, with cement, during surgery, it would just not get cured. Then you do it again until you're sure you have it's well cured, and then you will have you keep the triossicular system, you keep the chain intact, and then what you have to do is indeed reinforce as well with cartilage.
Okay, but you know, you say you lose nothing. Well, you do lose something, because if it isn't successful, then you end up having to have it redone. So let's just look at this. What is your success rate?
We had a look. We have a study where we compared interposition with cement, and we have a statistically significant better improvement with cement compared with autologous incus, remodeled incus interposition. And where you also have from time to time with incus interposition, the problem is that you sometimes have a dislocation at one or the other end, what makes that you really...
Okay, well, let's just pick up on that, because you're talking about using an autologous incus, yeah, an interposition incus. Can I just ask here, who uses an interposition incus as part of their normal reconstructive pattern? So we have, you know, possibly, what, 10%? 15%? Yeah? Does anybody on the panel use interposition incus? You do? Okay. Okay.
I don't say that it is a bad procedure, but in this indication, I think cement has certainly a good place.
Okay. But what is the fail rate? What percentage of them eventually disarticulate?
They don't disarticulate. Honestly, I don't have one case where you have a real disarticulation. What you could get is, if you put too much cement, you could get an ankylosis. That is the
what cement are you using?
Hydroxyapatite. Don't use Seronosem.
Correct.
Because Seronosem can give inflammation. There are cases described, even late inflammation, whereas with hydroxyapatite, I've never seen a case where you had an inflammatory reaction afterwards.
I think that's very important.
Even with retraction, with collapse of the tympanic membrane, you sometimes see the cement through the tympanic membrane and no reaction at all.
No, I agree with that. Seronosem doesn't work. That does fall apart. Any comments from so would anybody on the panel use a chip of bone as averse to an interposition incus and or anything else? I see. So in other words, would you bridge the gap first with a piece of bone and then put the cement around the bone?
No, not in this case. In this case, it's very easy. In some cases, the bridge is too large, and what I do then is use just a Vicryl 5/0 little piece of thread, and you put it on the incus and on the stapes, and then use this as a guide for your cement to béton armé.
What about a helix?
Well, that's an
a
alternative.
Krauss helix.
Yes, that's a good alternative.
That works very well.
Very good.
Yeah.
Yes. I have no experience with it because you have anapprosthesis and the cement.
You know the Krauss helix, which is like a double helix at right angle, and that works very, very well if you've got a very large gap and using cement. That gives very good results. So anyway, so we've got cement, we've got autologous incus. I'm going to ask you for your opinion, but hang on, first of all, the question. The
question is because today we heard a lot about prosthesis and interposition of incus, and nobody ever mentioned autologous malleus head. So I would like to know, is that completely out of fashion or is it still used?
Please answer the question.
Yes, I don't use cement. In this case, this patient had two problems. One, ossicular chain, and the second, retraction pocket that create the resorption of the incus. So, in this case, I do endural approach of Hermann in Chile, local anesthesia, and I just put over the capitulum of the stapes a slice of tragal cartilage. So it prevents also the retraction pocket. I don't touch this incus. I don't touch this. I just put over the larger piece of cartilage. My results are very good, especially in the long term.
So do you do anything? You just lay cartilage on the stapes?
Just cartilage of the stapes.
Okay.
Without any kind of prosthesis.
Okay. Thomas, do you put cartilage as well?
But cartilage to reinforce the tympanic membrane, because this tympanic membrane could go on retracting and cause a cholesteatoma. So it's in prevention of a further retraction, one. Second is some of those patients are complaining of a pressure sensation and even sometimes pain. And sometimes it's even that reason what leads to surgery more than the hearing loss in some cases, where patients say, well, you know, this is bothering me a lot. And it is a way to get...
Belgian patients.
Well, they are quite nasty and difficult, yes.
Let's ask about the French patient.
Yes, and the version now. I would like to do a cartilage tympanoplasty, sure, for the retraction pocket, and the TORP. TORP, ossiculoplasty, TORP in hydroxylapatite.
So basically, we have,
all the possibilities.
ladies and gentlemen, we have cement, autologous incus interposition. We have no interpositions, just cartilage. We have a TORP and cartilage. Okay, so you've got 4 options. Out of curiosity, let's take option 1, cement. Hands up for cement. Hands up for, what was the other one? No, just cartilage. Okay, let's have hands up for, what the hell else have we had? TORP. TORP. Hands up for TORP. And cartilage. Well, I'll tell you what, it's a very split audience. So we'll move on to the next case and see if we can... Oh, sorry. Yeah. The question here, though, was, and I'd like the panel to answer, the question was, does anybody still use autologous head of malleus?
So what we didn't discuss was a PORP in this situation. And I would not use the head of the malleus because I'm assuming that the ossicular chain is mobile. The lateral ossicular chain is mobile. And you can actually put a PORP on top of the stapes using the incus to stabilize the head of the PORP and put cartilage posteriorly on the tympanic membrane to get a very good outcome. And I would not use the head of the malleus because it is still providing stability for the prosthesis in the ossicular chain. And you're essentially nearly reconstructing the lever mechanism that's going to reestablish near normal movement. And if the cartilage is 0.4 to 0.6 millimeters in thickness, the tympanic membrane should vibrate fairly normally. So I would be a rebel, be controversial, and say I'd use a PORP.
I don't think that's being a rebel. So I will just ask the panel.
Why I said a TORP more than a PORP? Because the PORP, you cannot manage it exactly to have a good position in between the malleus and the foot plate. And sometimes, especially in case of anterior retraction of the handle of the malleus, your PORP is quite oblique. And sometimes with the TORP, you can, as you saw this morning in the communication of Robert, you can cope with the differences between the position.
Apparently, none of the inquest nobody did mention the underlying pathology and if they have any solution to it.
We'll come on to that.
Tube, it was mentioned, but anybody will put a grommet here permanent ventilation?
We're going to come on to that in a little bit, actually.
We're going to come to more of that. We did
on.
mention it, and I kept saying no, 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 no. Okay, so we're going to move on now.
I would put a PORP on this with cartilage. I think you can angle the PORPs quite easily to match the drum. And I would use a Dresden clip, but we'll talk a bit about this tomorrow. Now, we're going on to another case. So this is a 47-year-old female, 5 years ago had discharged, and she's left with this. Not hugely dissimilar to our last case, but it's subtly different, and I just want to show you the surgical finding, because we went through the same process of hearing aids. We said, look, we're surgeons, here's a hearing aid, it's a huge box, you can wear that, it's very ugly, or you can come and we'll do wonderful surgery for you. Which would you like? So she decided to go for surgery. So this is the surgical finding, okay? So it's subtly different from the last one. There's no actual complete gap here, there's just a fracture. So you might say this is a perfect case for cement. What I'd like to know from Benoit is, what would you do with this one? Because on the last case, I think you were going to put a TORP in. What would you do for this? It's got a pretty big conductive hearing loss. What are you going to do?
The same.
So you're going to do the same. So the fact that this is a very nearly intact chain has no bearing on you. That's fine. I'm just asking. Yeah, exactly the same.
But I have no experience with cement.
So is there any cement used here in the clinic at all? Only outside in the building side?
No, yes.
Yeah.
At the moment we have a lot, but not the good one.
Okay, and Thomas, I guess that the answer for you is going to be the same. You use cement for this. Okay. And maybe the same for you? You're going to use cartilage on this one, just the same? Because that'll sit nicely on top? So anyone do anything different? Yeah. Thomas?
What I don't like is the high tone loss and the large air bone gap in the high frequencies.
Yeah, okay.
I wonder why this is the case.
Yeah, okay. Yeah, of course.
That was exactly what I was wondering about. That's kind of strange to get that high frequency conductive loss. So one of the things to think about is an incutomalleolar separation. So that there might be a little bridge there, but that doesn't explain the degree of hearing loss. So sometimes you see that high frequency loss when you have incus malleus separation, or fracture of the malleus sometimes as well. That's something you should look for in these kinds of autograms.
Okay, I mean, this is one I did put cement on and actually did very, very well. I don't use HA cement, so it's something I'm look at. Okay, so we're going to go on to the next one.
Sorry, Chris,
really want some advice
just before you do.
Yep, sorry.
There's a connection there, but it's a bit of tat, isn't it?
Yeah, it's not much. If you look at the hearing loss, it's not too much.
Most of the long process of the incus is just fibrous or mucosa. So if you're going to put cement on there, surely you're going to do something to clean that off, and you're going to be left with virtually nothing.
So what can I just ask Thomas, what do you do in preparation of the ossicular chain prior to putting cement on? Do you do anything?
Yes, in this case I will curate a little bit the posterior sulcus, and I would remove some of the mucosa over the bone, just to make it adhere better. But you have to end up with as dry as possible situation before you put the cement, and then you ask your nurse to mix the solution with the powder until they get like a dough-like substance, which is not too fluid and not too stiff. So they know by time, they know the exact texture you want to obtain, and then you apply it, and then you have to wait 7-8 minutes. That's the most difficult part of the operation, is the waiting, the curing. We as surgeons, we are very
impatient.
Impatient.
Particularly the Belgians.
Thomas, what's the texture that you like? You say she knows. What is that texture when you're ready to put it in?
It is just that it sticks to a micro pick, and it will be like a ball. Just stick, and then when you apply it over one end, and you just go from one end to the other, and it will. Eventually I can insert a little video tomorrow.
Yeah. Okay, so we'll hear more about that tomorrow. But in terms of actually cleaning it, you just, with a micro pick, just take off the mucosa.
You take off some of the mucosa, just to prevent but in some cases where it's difficult to get it off, mainly from the capitulum, then I tend to leave a little bit behind as well, because a pseudo articulation is not that bad, actually.
No, sure.
because that's what it is. What you have is an articulation. So to have
So in a way, you don't want ankylosis in a way.
No, you don't want it too much, because I've seen a case where I had to go back in a cholesteatoma because of a recurrence. I took out the incus stapes as a whole, and we analyzed it under histologically, and you really have an osseous binding, ossification in the hydroxyapatite. So have a real bony bridge.
And have you been back in where, I mean, I know you said they don't disarticulate, but have you been back in where you've actually had problems removing the cement? I mean, this.
Yes, I think that can be a problem. So I think in that case,
you laser it away.
Laser.
Yeah. Okay. All right. So this is a patient that's just. The cost of the cement.
Cost 250 euro, but. We divided over several.
I think that's about $50 now after the Greek thing.
It's 320. It's $320 in Canada. Right?
No, that was meant to be humor. Sorry. Okay.
Oh, first ones, yes, for something.
So certainly in the UK, the cements, I don't know about HA, but the cements are generally a bit cheaper than a prosthesis, which is probably reasonable given it's just a tube of toothpaste. Okay, so this is one that's troubling me. I'm sure you see cases like this. This is a 15-year-old girl. She's had grommets on both sides, and when she was younger, and now she's got this ear, and it intermittently discharges and then sort of settles down. She's a very keen athlete, likes to swim, but she's got pretty much normal hearing. So let's just go along. And so the question here is, do you operate? What would make you operate? When would you operate? Would you wait? What sort of things would make you determine your decision on this?
So I don't necessarily see this as a very difficult problem. I see it as a very difficult surgical problem if you want to operate.
Okay.
And she has normal hearing, and what I would do is after she swims, I would have her irrigate with an acetic acid solution in her ear and keep it acidic and irrigating it out, and I bet you could manage your drainage well.
And she swims 7 days a week, so that's fine to put acetic acid in 7 days a week, is it?
No problem.
Okay.
You just smell like a cucumber salad.
Yeah.
Other than that, you're good.
Fish and chips, we would say in the UK. Yeah. Okay. I'm taking this back to her, so I shall tell her that. I think she'll be delighted with the.
I usually get them put the vinegar in before they go swimming. Then it's
so vinegar is obviously the thing here. Good. Okay. She does intermittently get discharge from this ear, and just to tell you the real story, 3 months ago she had a granulation polyp up here, but it did suck out and settled nicely with, this is her most recent picture. It's a little bit of just keratin just accumulating on this corner, but when you put an endoscope in, it does look clean around the corner. I've checked her, there's nothing going around that corner. So it's just she's intermittently discharging. So basically your advice is as long as she doesn't get much in the way, just do nothing.
Well, can she Valsalva this out, Chris?
No,
she can't pop this out at all?
She can't.
I mean, that's a remarkable hearing result for that little air ventilation at the top, which you do see sometimes.
It is really, you think it'd be much worse, but this is, some of these are obviously made up. This is not. This is from the clinic last week.
Is there an anterior segment you can put a tube in?
She's had tubes before, and I can't remember exactly when the last tube is, but this is a drum that doesn't hold tubes very well. It's very thin. So does anybody... Nothing. So with Valsalving, nothing. So does anybody sort of say, well, this is a 15-year-old, she's bound to get a problem, this is a prophylactic operation, we're going to do it now before she erodes a chain? Nobody do that.
Do you know what, one thing I've done is patients like this, a bit older, I've actually polysterized them, and I've been able to push that out, even though they can't valsalve it. With a pulsar balloon, I can push it out and then put a tube in sometimes.
Yeah, okay. Yeah, we'd come to that. We'll come to that. Okay, so nothing else. Thomas, Franco, you wouldn't operate on this one?
You operate?
Yes.
You can. I have triathlete.
Yeah.
She's intermittent right otorrhea, so she's invalidated by this problem. Then why not operate? I operate with cartilage. Also because there is some debris, epithelial debris.
Yeah.
Even if not, she's young, she can develop a cholesteatoma. She needs to swim without problem. So of course, the hearing is normal. I always discuss about the operation, the cost-benefit ratio with the patient before we do appropriate counseling, appropriate informed consent. But I operate with palisade cartilage.
Okay, so let's just. I this patient's probably slightly worse than you see. She does get problems with it. I'm not convinced that at 15, with 80 years ahead of her, the vinegar's going to do it. But I might be wrong. Maybe she'll go her whole life just using vinegar.
Why all our ear patients like so much to swim? They all like to swim.
Yeah.
It's incredible. They all like to go and swim. But
So
indeed,
what
I
might make you change? What would you see, Doug, in this patient when she comes back to see you and she's been using the vinegar? What would make you change your mind about operating?
I think that she started accumulating squamous debris.
Yeah.
I think the biggest challenge is that we see a lot of horrible-looking ears, but we really need to treat symptoms. And I think, we could operate on this. We could theoretically do a complete tympanic membrane graft with cartilage. If you look at how that progresses, we could probably give her a 15 decibel conductive hearing loss by elevating her graft. And the risk is that by the time she's 25, she has a modified radical cavity. Because if she's going to retract like this, she's going to retract around any gaps you leave in a cartilage graft. So, but I think, if she started generating debris, and a lot of these folks will do very well, and then they'll get a cold, and they'll get fluid in their ear, and they will drop their hearing, and it doesn't resolve. And they're very poor grommet patients. So at that point, not operating now doesn't mean you won't operate when she's 25.
No, sure. Okay, good. Well, that's very helpful.
Think about these patients, often at the age of 15 or so, are close to exams and things like that, or at least in Canada, that's a big exam at the age of 16. So I'd be really worried about getting hearing loss around that time. Wait till they've passed the exam period, and then we have much less to lose at times like that.
So I just want to throw this one open to the audience. Is there anyone there who's going to operate on this 15-year-old prophylactically?
This is a 15-year-old who already has this is a 15-year-old. She's symptomatic from what looks at least like grade 3, probably grade 4 retraction. There's nowhere this is going to go but worse. And yes, she's probably going to get a little bit of a hearing loss, but is that going to be clinically significant? 15 decibel versus otorrhea that's probably affecting her, potential athletic life. I'll just, sit down and have a discussion with her, but I would personally operate. I would push toward operating on her.
That one slightly differently at 15 is that depends on your healthcare system, and if you're able to follow her up carefully, as Chris is for some reason or other, you can endoscope that and keep an eye on it. She's going to get a big conductive hearing loss eventually, but nature's done that, and then you can reconstruct. If you go and operate on that now, both she and her parents are going to be very pissed off when you get a poor hearing result, I suspect. And, we're all a sick concern here, and I couldn't guarantee to give you a good hearing result there. Yeah.
But I'm addressing her current symptoms.
I agree. Yeah.
She did already test
Yeah. But you're also going to tell her, by doing this, I may well take your hearing away. 25%.
I think one of the really strong issues is that at the moment she's still got an intact ossicular chain. If she progresses, and unless you follow her up closely, which Chris tells me he does in her case because she's very pretty, and that's a good reason, but in reality, this can progress quite rapidly, and you can end up with erosion of the ossicles. Then your problems are compounded. So I think,
Let's just put out to the audience. So do we operate now before she gets an ossicular erosion, or do we wait and operate when she's got the hearing loss? Who would operate prophylactically now to try and prevent problems?
And additionally,
okay, and those who would wait. I mean, clearly, if she comes and she's got a hearing loss, life's easy for the surgeon. But you do have the chance here of preventing issues.
Salva maneuver on a daily basis, like 50 times a day. What I tell my patients for 6 months and then follow them up.
Okay, well, I've never asked them to do it 50 times a day, and I suspect in the UK they wouldn't do it. But I am a great fan of Otovent balloon and the ear popper. So I give all my patients, if they don't Valsalva, I give them that.
What you could do, I think, in this case, is to try under general anesthesia to do a paracentesis, put a ventilating tube, and instill with something like fluimicil to try to elevate this tympanic membrane, and then just resect the excess of tympanic membrane and let it heal. That's something that is not very traumatic. You're not doing a cartilage tympanoplasty, but at least you give the ear a chance to recover.
Franco.
Additionally, you know that intermittent otorrhea since youth increased significantly the risk of sensory neural hearing loss. So
No,
it's
true.
another reason to operate.
Well, I mean, this is clearly a tricky case, isn't it? We're going to go on to the next one.
My view on this is that we should just cancel the patient, talk to the parents, and give them the options. We make it difficult for ourselves here by saying you must do this or we must sit back and do no surgery. Give the options open, and an operation where there may be a small hearing loss may be more beneficial to this patient than getting discharging ear in the future. Throw it back to them.
And Chris, another
Well,
thing.
that's exactly what I've done. But this is a family who say yes, we'd like surgery, and then they cancel it and say, oh, we've decided we don't want a surgery. And we've booked this several times, and they've cancelled it. And I did mention I would come and get the opinion of the wise people here, and I can go back and say there's no consensus here. But clearly there's no consensus. These are tricky cases. I think we'll go on to the next one. Can we do that? Okay. So this is a question really for you about what your threshold is operating on a clean ear purely for hearing. Where do you feel in your own practice you'd be comfortable that you're going to get a good likelihood of an improvement in hearing? So there's left ear, it's a ventilated ear, slightly retracted, been ventilated a long time, but it's got a relatively small airbone gap. What's your threshold, Franco?
In this patient, I also operate this patient.
You would operate this patient.
I operate this patient.
And this is purely for hearing. There's no question of discharge here. It's an old lady. She's not a swimmer.
I know, but I'm sure that if I put a small slice of cartilage over this capitulum of the state, I will stabilize the posterior superior aspect of the membrane, and the I will reduce also the autophonia of this patient.
So you would do it at 15 decibels. What about if the airbone gap was 10 decibels? What's your actual threshold for doing this? At what point do you say, I mean, clearly if it's 2 decibels, you're not going to do it. At what point are you, because we're doing it purely for hearing here.
It's not only a question of hearing threshold, hearing decibels. It's a question also of other associated symptoms.
She's got none. This is a question. This is a question about your threshold for airbone gap. At what point do you say?
It's stapedotomy. I don't operate if
it's not stapedotomy.
Yes, in this case, I operate only if the patient complains about some autophonia, or especially if she asks me to improve.
She's asking you that. She's asking you that. I'm asking you. I'm asking you. Because ultimately we have to know our own figures.
10 decibel means a change in the speech understand in noise in this patient.
Yeah.
She's not old, but she's has also some presbyacusis.
She's not old. She's 63.
No, not old, but she has some presbyacusis also. You see.
Yeah.
Probably, or
okay.
Yes, I operate. For me, this.
Thomas,
I certainly would reschedule this patient for a new audiogram, because I don't. Well, it's not that I don't trust this audiogram, but I want to make sure about the air-bone gap, and maybe next time the air-bone gap will be larger. If it's smaller, I certainly would not operate, and even in this case, I would not operate. I would resend it to the audiologist for a hearing aid.
So you'd counsel for a hearing
aid?
Weber test.
Yes. I'm a great fan of tuning fork tests. Great fan of them. Okay, so now we, Doug, now you know this is why our patients go for surgery, because this is the latest on the NHS. What about BAHAs? What's your threshold for a BAHA on a patient like that? What would make you decide that one, Manohar?
For someone like that audiogram?
Yeah. Is she too good?
Yeah.
The other is too good?
Yeah, I mean, I see that most of all, her hearing loss is not the speech frequencies, and speech frequency is only about 10 dB, so which is not going to help speech very much. Second of all, I want to know what the middle ear pressure is. If she's got negative pressure when that was done, maybe a ventilation tube will bring her 10 dBs up, and that might close the gap for all you know.
It might lift it off the stapes head, of course.
It might, but but it looks pretty well fixed there.
Yeah.
So I would not touch that particular ear, and I don't see that is a BAHA candidate in my mind either.
Okay. Right, so this is, for all of you really, you need to record your data, because you're going to have, we all have patients like this, and we all have thresholds that we're very happy about on both ends, but there's a bit in the middle, a grey area. Unless you record your data, you can't really decide what you should be doing. Okay, now tonight you're going to go to the Chateau of Roger Autier. You've been for lunch today, and one of the nice things about this course is that the French are very generous with their wine. So, you know, in the UK, you'd never get wine at lunchtime. We wouldn't be allowed. I did notice that quite a lot of you were sleeping this afternoon. But I just want to explain to you why the French are so generous with their wine. This is their new... I hope this will work for you. Oh, bugger. Excuse me. We're going out live on the internet. Oh, no. One more. There's just a slight delay on the sound, sorry, because it's wireless. There we go.
Cet appareil est le USB Wine et c'est génial. Et maintenant, vous aussi, vous pouvez accéder à cette extraordinaire technologie depuis chez vous. Regardez comment fonctionne cet appareil révolutionnaire.
Vous branchez l'USB Wine à votre ordinateur. Vous accédez au Wine Store dès votre USB Wine connecté. Vous visitez les meilleurs vignobles dans le monde d'un clic de souris. Vous choisissez un vin et commencez le téléchargement. Votre vin se verse directement de l'USB Wine dans votre bouteille.
Et vous avez en plus l'étiquette. Waouh!
Quel produit révolutionnaire!
Et durant notre offre spéciale,
Okay. So there you are. So enjoy your wine tonight, but you have to realize it's not seeing much in the way of grapes. So I think that's probably about right for now. I'd like to thank my co-inquisitor David, and I'd like to thank our panelists for being great sport.